almost there. Okay, and we are live. Hi, web shadowers. Thank you all so much for joining our session today. We have the pleasure of hosting Dr. Monisha Bhanote, who will be presenting on integrative medicine. As always, please remember the Google form will be posted in the comments and also in our Instagram bio at the end. With that being said, you can get started whenever you're ready, Dr. Bhanote.
Thank you so much, Sophia. I'm so glad to be back with Web Shadowers today. This time around, I will be presenting integrative medicine, which I'm really excited to share with you. There'll be a little dose of pathology put in there as well, but the focus for this session is all about integrative medicine. So with this, giving you an overview of how the talk is going to go, I'm going to tell you a little bit about my experience, an overview of what integrative medicine is, a day in the life of an integrative medicine physician, our patient case, and then open it up to a Q&A. So a little bit about my experience. I trained in New York with internal medicine first, and then I moved on into anatomic and clinical pathology at NYU Langone. I did a cytopathology fellowship at Cornell, followed by a breastbone and soft tissue cancer fellowship at the University of Rochester. Additionally, I have done another fellowship in integrative medicine at the Andrew Weil Center for Integrative Medicine, as well as training in culinary medicine. So what exactly is integrative medicine? How do we consider that in the realm of all the different types of medicines we look at compared to internal medicine, family practice, essentially anything? Where does integrative medicine fall in? Well, integrative medicine combines the best evidence-based practices from both conventional and complementary therapies. It results in a complete and well-rounded healthcare model. So what I like about this type of practice is it is not alternative. And that's something that I want to have people realize, because it's not an alternative, one or the other. It really uses what's going to be best for the patient, whether that is using a conventional approach, and it adds complementary therapies to this to perhaps make the conventional approach work better, or sometimes maybe even the complementary therapies might work better for the patient. Integrative medicine modalities include botanicals, mind-body, and other evidence-based therapies. There is a comprehensive history, a thorough physical exam, and advanced diagnostic testing, which allows us to get to the root cause or the underlying cause of the illness. And what we do is we do a personalized approach where the doctor and the patient work collaboratively to make a treatment plan. So basically working together, the doctor and the patient, along with other professionals when needed. So the different subcategories that fall under integrative medicine, that if one chooses to pursue a career in integrative medicine, is botanical medicine, herbal pharmacology, integrative nutrition, mental health, mind-body medicine, phytonutrients, dietary supplements, aromatherapy, essential oils, nutrition and cardiovascular health, environmental health, integrative sleep health, integrative oncology, integrative women's health, integrative gastroenterology, mind-body stress reduction, integrative rheumatology, integrative pain management, and then the whole body systems of traditional Chinese medicine, Ayurvedic medicine, homeopathy, and the newer finding of functional medicine. So with this, how can we compare integrative medicine to our conventional type of medicine? When we look at integrative medicine, we are patient-centered, meaning we treat the patient, not the disease, where the conventional model treats the disease, not the patient. So in the conventional model, if you go in for a certain symptom, a disease, you are labeled with that disease and you are treated with a protocol based on that disease. So integrative medicine applies a personalized, individualized care approach The conventional medicine might provide a care based on the diagnosis and not the individual patient. One of the major factors is with integrative medicine that looks to address the root cause rather than suppressing these symptoms without addressing the underlying cause. Integrative medicine treats the body as a whole, recognizes the connection that there is between the mind, body, and spirit. Conventional medicine can separate the body into disease system based on organs and silo medicine out, where one specialty might only be focused on, for example, the GI tract, or, somebody who has migraines. Now, we're getting a little bit closer to some of these integrative and conventional paradigms realizing and connecting with each other. But in the past, what I've seen is you come in for some kind of digestive issue and that's what's treated, or you come in for a migraine and your migraine is treated, but the connection there is not so readily explained or observed or connected. In integrative medicine, the goal is to do no harm. So treatments may have minimal or no side effects, where in conventional medicine, we can have complications and side effects. In integrative medicine, the patient plays a key role and is active in their treatment, whereas in conventional, the patient is an inactive participant, basically given a prescription and lists of tasks that they must do for healing. The integrative medicine approach is designed to promote optimal health, reverse disease, and improve quality of life, where conventional medicine is designed to manage the disease and prevent death without addressing the underlying cause. Integrative medicine does a preventative approach to ward off disease before it appears, whereas conventional medicine focuses on managing the disease after it manifests. Integrative medicine is evidence-based with research from expert and medical professionals. Conventional medicine can be highly influenced by insurance companies and pharmaceutical companies. There is not one right or wrong way to do medicine. I think if we take a combined approach of looking at all these aspects of medicine, we will be able to better help our patients. And that's truly what an integrative medicine approach is. It is not one or the other. It is not alternative. It is truly complementary to both the conventional model and the integrative model. So with that being said, what kind of training would you need if you wanted to work as an integrative medicine practitioner? Well, there are a number of fellowships. I think last I counted, there is on average about 15, a little bit less than 15 fellowships available, which you can see which programs offer them at the American Board of Physicians Specialties website. But I'm just listing some of the well-known programs here. The Andrew Weil Center for Integrative Medicine in Arizona is where I train. You also have a program out of UCSF at the Osher Center in California, another program at Stanford Hospital in Connecticut, another program out of Illinois, another program in Michigan at the University of Michigan. Cornell also has an integrative health and medicine fellowship, Thomas Jefferson in Pennsylvania, and George Washington in DC. Now, the length of these fellowships might vary, and how you get into them might vary. I can tell you from my experience that the Andrew Weil Center for Integrative Medicine Fellowship is a little bit over 2.5 years. And it requires, and actually sitting for your board exam in integrative medicine will require you to be board certified in one of the specialties. So you might have done internal medicine before, you might have done family practice, you might even have done surgery. My colleagues that I trained with during my fellowship were from OBGYN, they were from surgery, they were from pediatrics. Essentially they came from multiple different specialties, and then they added this on as a fellowship for them. So sitting for the exam, you need to have completed a fellowship from one of the recognized places, or be in a specifically other accredited program. So I'm seeing a question coming in here, and the question, let me answer that before we move on. How rapidly does integrative medicine change according to shifts in culture? Does integrative medicine look into the effects of new diets like raw food, ketogenic, etc.? That's an excellent question, because one of the primary things that we do is we are focused on diet as an integral part of the healing process. So we do keep a breath on all the different diets out there, what has real evidence, what is a trend, what is a fad. And like I said, integrative medicine is evidence-based. So we do keep on top of those for sure. So where can you practice in integrative medicine? So I did a survey with my colleagues and asked them what types of facilities they are practicing in. I myself have a private practice. There are physicians who are working in academia, so they might be at a university setting where they are incorporating integrative medicine modalities. Some have wellness facilities where it's kind of their own practice, but then they've also incorporated some kind of other therapies. Cancer centers now, if you look at some of the major cancer centers in our country, MD Anderson has an integrative facility. Memorial Sloan Kettering has integrative medicine. There's a number of large facilities that are incorporating integrative medicine. Also, we are seeing some physicians work at the VA to bring that in as a type of healing for VA patients. I have a colleague who's at the Indian reservation, and then even some that are working in the underserved community. The whole goal is to see how we can really help heal the patients rather than put a Band-Aid on for their treatment. So personally, I believe that there is a space for integrative medicine in every specialty. I would say that, you know, integrative medicine in itself has become a buzzword of sorts, where everybody is putting that integrative medicine word in front of their specialty, and I'm grateful that it's getting some recognition, but there is a serious amount of training and knowledge that goes into that, and background. Like I said, my additional fellowship is 2.5 years in integrative medicine just to complete the fellowship, and there is a board certification. So I definitely recommend, if somebody wants to, if you want to send your family member or somebody to an integrative medicine physician, that you check out their qualifications to see where they actually trained. So back to that question you're asking. So what does an integrative medicine physician do? So this is what I do, and this is what I'll do after, you know, our live today is I go in, and my appointments are generally, my initial consultation is generally 90 minutes. Yes, that sounds long. I spend a minimum of 90 minutes in my initial consultation, and all my follow-up visits are 60 minutes. In that initial consultation, I'm basically trying to get a good idea of everything going on in an individual's life, from their social habits to what kind of exercise routine they have, what their nutrition is. I have a lot of clients come in and tell me that they eat really, really well, and that they think they're doing a healthy diet. And then when we actually talk about it and what they're doing, and we realize that it is not as healthy as they thought. Also, we talk about their medications, supplements. Supplements is another big one. All my patients bring in their bagfuls of supplements. They put them out on my table, and we look at the quality of these 20 different bottles that they are using and spending lots of money on, to really see what is the quality of their the supplement. Are there any fillers in there? Is the supplement actually helping them? And we try and simplify their plan. So instead of taking maybe 20 supplements that is really not helping them, down to the real ones that they need for their specific body. We also talk about stress and mindfulness and how they can manage it, providing techniques for them, for their individual way of being. Not everybody is going to be a meditator. So we talk about what other applications of mindfulness we can apply. We talk about good sleep hygiene. Sleep hygiene is so important for our healing. So that is a very integral part of the conversation. We also talk about spiritual and emotional care and environmental exposures. Now, this is just to name a few of the things we talk about. And that's part of the reason the appointment is very long, because you're not going to get this in a 5 to 15 minute appointment to really understand how to help your patient. So let's go on to a patient case here. So I'm going to give you a patient case that has been written up in one of my previous books, Medicine Morning Report. And I'm going to take you through this case of how it was written for a conventional medicine approach and how we would address it as an integrative medicine physician. So this is a 35-year-old male. He presents for his annual health exam for work. He has a past medical history of asthma and seasonal allergies, which are well controlled. He reports a 3 to 4 year history of burning, substernal, non-radiating chest pain that can last up to 2 to 3 hours and is associated with large meals, worse at night when he lays down and goes to bed. Upon questioning, he denies any feelings of chest pressure or heaviness or tearing, ripping feeling in his back. The patient also notes an occasional acidic taste in his mouth. He had not sought medical attention because the pain quickly resolved with antacids, but now the pain seems to be more severe and frequent, and antacids no longer provide relief. He denies any nausea, vomiting, hematemesis, melena, hematochezia, diarrhea, or constipation. Now, he has a traditional or general symptoms of one entity that you might already be thinking. So on physical exam, we see his blood pressure is 132/75 in his right arm, 130/70 in his left arm, with a pulse rate of 74, respiratory rate of 14, and 100% oxygen sat. So he's well developed, comfortable, equal pulses. So, and his chest pain is not reproducible. His heart and lung sounds are unremarkable. His abdomen is soft, non-tender, non-distended, no peripheral edema. So essentially, he has a normal physical exam, but yet he doesn't feel well. All right. So chest pain, as we know, is one of those red flag symptoms that requires a clinician to at least consider some of the life-threatening pathologies, which may include acute coronary syndrome, aortic dissection, pneumothorax, and pulmonary embolism. So because these tests and conditions are very costly and time consuming, a detailed history and physical exam is the most important first step in an evaluation. And that comes with essentially anything you're doing. In any career in medicine that you choose, getting a very detailed history and physical exam is going to put you steps ahead in figuring out what your differential diagnosis is and really helping the patient. Also, we want to identify risk factors for the patient. So the clinical pearl here, and something that, you know, is considered a clinical pearl that it might show up on a test question for the USMLEs or any types of exams, is the classic symptoms of GERD include substernal burning, discomfort, and acid regurgitation. Atypical symptoms may include chest pain, asthma, hoarseness, chronic cough, and laryngitis. So what is the most likely diagnosis in this patient? The most likely diagnosis is reflux disease. So gastroesophageal reflux disease. When you have a relatively young patient without risk factors for other conditions, it is appropriate in the conventional medicine model to start empiric treatment with close follow-up. So The differential diagnosis that you would want to consider in reflux disease is infectious esophagitis, pill esophagitis. These are unlikely, and you might get this kind of information from their clinical history as well. And then some alarm features in someone presenting with gastroesophageal reflux disease is dysphagia, and all these ones that we already really question him if he's having. So how would we manage this patient? So like I said, the initial management consists of an empiric trial of acid reducing agents, as well as lifestyle and dietary modifications. So these can include eating smaller meals, avoiding late night meals or snacks 2 to 3 hours before bed, avoiding the common precipitating foods, stopping smoking, losing weight, and elevating the bed for sleep. So this patient is informed of his diagnosis. He is counseled about weight loss, lifestyle, and trigger foods, and he is also prescribed a proton pump inhibitor. And then he is scheduled for a 1-month visit for follow-up. So one of the things that we need to know about proton pump inhibitors, any medication that we are taking has its own risks and side effects. So proton pump inhibitors are one of the most frequent causes of drug-induced acute interstitial nephritis, which can sometimes lead to renal failure. Chronic PPI use has also been associated with hypocalcemia and magnesium deficiency. And studies even suggest that there might be a concern for dementia risk in those who take chronic PPIs. I know a number of family members and friends who have their grandparents on long-term PPI, and they talk to me about symptoms of dementia. These people have been on PPIs for 30 years because nobody ever weaned them off. So it is something to take into consideration. PPI has also been shown to be associated with a SIBO risk when used with highly accurate testing. So what happened with the follow-up? The follow-up of this patient, the patient returns a month later and he says his symptoms are improved, but he's still having some bothersome symptoms despite being adherent to his medication. He admits that he was not very strict with the lifestyle modifications, although he thought, his thought and his defense in that thought was that the medication will take care of everything. And now he worried that something else might be going on and he wanted further evaluation. So and I'll revisit this later, there are common foods and medications that can precipitate reflux disease. The well-known ones are chocolate, caffeinated beverages, alcohol, spicy foods, and then there's even certain medications. One to consider is oral contraceptives, so birth control pills. So with that being said, what would be an indication to refer him for endoscopy? So generally, patients are referred for endoscopy after they have failed an empiric trial of twice daily PPI. And I see one of the questions coming in is, what is empiric trial? Like, what is that? So essentially, we know a certain medication can possibly help resolve the symptom. So without having, the empiric trial is basically, we're putting him on this trial to see if that medication, and in this case, the PPI, is going to help his symptoms. So empirically, we're just trying this up front based on his symptoms. He essentially failed this. So now he can be referred to endoscopy. So the purpose of the endoscopy would be to rule out alternative diagnoses, some of the differentials that I had mentioned before, also to see the severity of the mucosal damage and to screen for long-term complications of reflux, such as intestinal metaplasia. So here, what we are seeing is, so the gastroenterologist will do a upper endoscopy, and what they're doing is they're looking at the images of the upper GI tract for areas of ulceration, areas of discoloration, just irregular areas. And depending on if they see those irregular areas, they will biopsy some areas. Now, for reference, I have put a histopathology picture of a relatively normal GE junction. So that's gastroesophageal junction, where here is the esophagus side and here is the gastric side. So here you can see that the esophagus side is lined by normal squamous epithelium, where the gastric side has the gastric glands. What happens with injury in reflux disease is as the acid washes back up with reflux, the gastric glands essentially have to find a way to manage this increase in acid. So what they do is they undergo metaplasia, known as intestinal metaplasia. So this picture right here is an example of intestinal metaplasia where we can see and identify goblet cells. So this is one of the histologic manifestations of reflux disease. What happens with this is long-term, long-standing intestinal metaplasia can eventually develop into dysplasia, which is the abnormal transformation of the glands into something that's dysplastic, which eventually, with even further long-term, can develop into cancer. So ultimately, the damage that starts in one end can quite a bit progress eventually to an adenocarcinoma. So we want to prevent all of this from happening. So the long-term consequences of reflux can be divided into two categories, esophageal and extraesophageal. I've already mentioned the esophageal, which includes the intestinal metaplasia, but it can also have a stricture. And these are consequences of the direct result of the healing and adaptation to mucosal injury induced by long-standing acid reflux. The esophageal stricture is typically treated with an esophageal dilatation, and Barrett's esophagus is managed with surveillance endoscopy to assess for dysplasia and possible malignant transformation. If dysplasia is discovered on surveillance endoscopy, then a patient might undergo endoscopic ablative procedures, possibly an endoscopic mucosal resection or a surgical resection at their GE junction, depending on the extent of disease. So now imagine that just from developing reflux disease, this and having it long-standing where it's not managed by a proton pump inhibitor could eventually down the road lead to multiple procedures and possibly even a surgical resection. So something to think about. Esophageal complications of GERD include esophageal stricture, Barrett's esophagus, dysplasia, and carcinoma, as I've already mentioned. And extraesophageal complications are chronic cough, asthma, laryngitis, and laryngeal cancers. So what happens to the patient now? So our patient in this story decided, since he failed the optimal medical management and lifestyle modification, even though he admits he didn't really adhere to it, surgery was his next option. He decided to undergo a procedure called a Nissen fundoplication, where in this procedure, the fundus of the stomach is essentially wrapped around the distal esophagus. And what this does is increase the pressure across the lower esophageal sphincter. So that's what he ended up doing. He ended up with not being able to be managed by his medications, undergoing surgery. So with surgery, there also becomes long-term consequences of this procedure. So the patient agrees to undergo the procedure. It went well for him, and his symptoms are under control, which is great. But that procedure comes with the consequence of possibly developing dysphagia. And this dysphagia in patients can present postoperatively and last for months, and then also require a modified diet, which, it basically is telling you that you still have to go back to that modified diet. Now, patients with dysphagia greater than 3 months should be evaluated with Barium swallow to make sure that they don't need further, like a revision, or that they need esophageal dilatation. Another consequence of this procedure is gas bloat syndrome. This is where the patient has a sensation of needing to belch, but cannot. And the symptoms might be addressed with adding another medication, or in extreme cases, adding a pyloric stent. So let's talk a little bit more about reflux. We're just going to step back a little bit and look at what is going on in the US with reflux. So the prevalence of reflux is rising worldwide. In fact, in the US, 21% of the population have symptoms at least weekly, and over 60% have symptoms annually. And this number is increasing as our population becomes overweight. Reflux results in 4.6 million office visits in the US every year. So it is very likely, as a physician, whatever specialty you're in, you are going to have a patient that will describe symptoms of reflux. So as for the physiology, the pathophysiology of what's happening in reflux, there's a number of things that can happen. So we can have abnormal peristalsis, we can have a defective lower esophageal sphincter, we can also have a lack of diaphragmatic pinch, abdominal pressure, gastric emptying, defects in the actual esophageal permeability. So there's many reasons for what is causing this. So when we're looking at the reasons of what is causing this reflux is where it comes to what kinds of medications they might be treated with. So the treatment of reflux is aimed largely at the reduction of stomach acid. So primarily, the medications we are seeing are the acid blocking medications such as proton pump inhibitors, H2 receptor antagonist, GABA agonist, and then sometimes if those don't work and we have another cause for what might be the reason for their reflux, promotility agents might be considered, pain modulating medications, and even anti-anxiety medications have been used. So the most popular medication option, as I've already mentioned, is PPIs. It's actually a multi-billion-dollar industry. And what it does is it creates a dependence that is difficult to reverse in those who are on chronic therapy. One of the main reasons to consider discontinuation of proton pump inhibitor use is the potential associations demonstrated with long-term use. So I've already mentioned drug-induced acute interstitial nephritis, dementia, also osteoporosis, SIBO. Now, we can also develop deficiencies in our absorption. So magnesium deficiency is seen, B12 deficiency, certain infections such as Clostridium, bacterial gastroenteritis, possible cardiovascular events, and an increased incidence of community-acquired pneumonia. So there are many things from one medication when used in the long term can cause lots and lots of problems. So which nutrients are getting depleted from PPI use? And I see that there was a question there about supplements. So for example, when we look for supplements that a patient is on, one, we want to see what that supplement is addressing. Is it addressing a true deficiency? What deficiency is it addressing in which nutrient? And then also, what is the quality of the supplement? So for somebody who's on PPI, more than likely that person is going to have calcium, magnesium, zinc, vitamin B12, folate, iron, sodium, and beta carotene deficiency. So when we're looking at what kind of supplements we're going to add, we're going to make sure that we're addressing these possible deficiencies, and we're also addressing them not only with a supplement, but with the food that they're eating. So what would an integrative physician do here? Well, possibly an integrative physician would consider weaning the patient. Now, I will tell you, and this is why I put it in all caps, it is a challenge to wean a patient off of a PPI once they become dependent on it. And also, it takes time to restore the natural physiology, but it can be done slowly and with the correct guidance. We generally draw serum gastrin levels because we want to make sure that we don't have any rebound hypersecretion. So when we do wean, it is done very slowly. And like I said, basically with a lot of assistance from the physician. So when I'm seeing a patient, so I spend a significant amount of time talking about lifestyle choices. So it's not a matter of me just saying, don't eat spicy food, lose some weight, stop smoking. It's not quite like that. What we do is we really want to help the patient in their day-to-day. So these lifestyle changes actually become part of their routine and they learn that it's possible. We do know that reflux symptoms improve if smokers quit and if obese patients lose weight. So our goal is to really help them find tools in how to address these things. We also talk to them about how they're sleeping. And we even help them build an exercise routine that is not only going to fit into their day-to-day, it's going to fit into their work, their travel, and everything else they are doing. So with that being said, there are dietary behaviors that we talk about. So we do talk extensively about their coffee habit, what is a possible replacement for that. We talk about how much alcohol, not just the fact that they're drinking alcohol, but what is the quantity, quality of the alcohol use, how often, what is a possible thing that they might be able to replace with that won't give them those symptoms, but still that they enjoy drinking. We also talk about fiber in their diet, the consumption of large meals, and their meal times. So as for studies, there are some conflicting evidence regarding the efficacy of these recommendations. So you're going to find a study on both sides saying whether it's good or whether it's bad. At the end of the day, studies, you have to really see where they're coming from. Are they being done by the actual companies who are endorsing the medications? So you really kind of have to be alert. Not everything's going to work. And that's where having an integrative medicine physician who really applies a personalized approach is going to help you. So with that, we do know that the lower esophageal sphincter normally exists in a contracted state. So when we swallow, it relaxes and allows material into the stomach. We also know that there are certain foods, medications, and other factors that can affect that decreased tone of the lower esophageal sphincter. So like I've already mentioned, common ones: alcohol, chocolate, coffee, cow's milk, orange juice, spicy foods, medications that people can be on. And also physiologic reasons. So there can be many reasons, and that's where you don't want to just put a label on a patient as, okay, they have reflux and I'm going to give them a PPI, because you really need to get to what is their specific cause of this. So an integrative physician might also consider botanicals with this patient. So there would be a conversation of using chamomile, licorice, marshmallow, skullcap, slippery elm, and valerian, depending on what else is going on with the patient. So we also incorporate botanicals. We might even incorporate some of the whole body healing systems. So for example, I don't know if you've heard about Ayurveda, but it is one of the oldest holistic whole body healing systems developed more than 3,000 years ago in India. So it's based on the belief that health and wellness depends on a delicate balance between mind, body, and spirit. So Ayurveda says that reflux occurs when an individual is out of balance, essentially when they have a pitta imbalance. So the goal is to neutralize the effect of the reflux. So just like in the conventional approach, the Ayurvedic approach uses similar methods of regular sensible sized meals, decreasing intake of alcohol and caffeine, avoiding eating before bedtime, losing weight if overweight, avoiding foods that cause exacerbation. So it's not unlike the conventional approach, but what it might do is also add certain healing foods, as well as maybe aloe vera, Indian gooseberry powder, apple cider vinegar, fennel seeds, and holy basil, which are less likely to cause the side effects of proton pump inhibitors do. So that would be part of the integrative plan, and also possibly an Ayurvedic plan. Now, additionally, a physician in integrative care might consider a TCM approach. Now, what is TCM? TCM is traditional Chinese medicine. And now this is also another whole body system that has been used for thousands of years to prevent, diagnose, and treat disease. Now, this belief system is based on qi, the body's vital energy, and how it flows in the body to keep the person's spiritual, emotional, mental, and physical health in balance. So similar, yet not similar. So when traditional medicine aims to restore the body in balance, it looks at the opposing forces of yin and yang, which can block qi or block the vital energy that is flowing through the body and result in disease. So traditional Chinese medicine may use acupuncture, diet, herbal therapy, meditation, physical exercise, and massage. In TCM, reflux is seen as rebellious qi, so rebellious body energy rising when it should be sinking. So in a study done in 2018, which compared PPIs to TCM therapy, they found that TCM single therapy can better improve the total effective rate and symptom relief and decrease in the recurrence rate and adverse events in the treatment of a non-erosive reflux disease. So there are studies available that show that there are other methods available to help with the approach of treating reflux disease. So like I've already mentioned, TCM, here's another study where it showed that acupuncture is highly effective in inhibiting intraesophageal acid and bile reflux and alleviating pain symptoms. This is an older study, but you can see it's been around for a long time. Not all patients are familiar with this. So another study showed that acupuncture, when compared to acupuncture versus a double dose of PPI, acupuncture was actually more effective. So even doubling the dose of PPIs, acupuncture came out to be more effective. So also something to consider. Now, there's also osteopathic manipulative therapy. Now, what is that? So we do have physicians who are trained, and they are physicians who attended the Doctor of Osteopathic School, and they are trained to do manipulative therapy. And what this does is using this manipulation, it helps to increase the parasympathetic tone, and that's the rest and digest tone. And it has shown to actually improve reflux symptoms. Also, deep breathing has been found to lower esophageal pain, hypersensitivity, belching, and PPI refractory symptoms. Once again, also increasing parasympathetic tone. So all in all, there are other alternatives to consider trying initially. And also if initially before you start a PPI, or even if you're weaning off a PPI to help you manage your symptoms. So what else would an integrative physician consider? So as I said, psychological stress can have an adverse impact on the gut barrier, affecting gastrointestinal motility and the course of gastrointestinal disorders. So psychological stress is definitely something we address in an integrative practice. We give tools for addressing this stress that somebody can apply daily. And the goal of eventually is to lower the sympathetic activity, because we want to lower the patient's pain threshold and increase the ability of the LES to function. So mind-body therapies might be used and important for healing patients. There's also culinary approaches. So part of culinary medicine is, which is also one of my subspecialties, is incorporating a meal plan and actually helping them, educating them on how simple and tasty meals can be when using certain replacements, and how it can actually lower their symptoms. So in summary, reflux esophagitis is a disease that is largely driven by our Western lifestyle, and the prevalence continues to grow despite the facade that PPIs are magic bullets for this condition. Esophageal adenocarcinoma is a direct complication of reflux, and its prevalence is increasing out of proportion to the higher rates of chronic heartburn. The conventional medical model is to give PPIs or consider surgeries, where other modalities are largely ignored or mistakenly devalued. So the integrative approach to reflux would include a thorough evaluation of the patient's lifestyle factors that may be causing the disease, a poor diet, being overweight, chronic stress, anxiety, medications need to be considered, and also corrected in an integrative and holistic manner. Patients are more likely to respond to lifestyle changes when they partner up with their doctor and they understand why their doctor is asking them to do this. So there is definitely a lot of education involved here, and explaining to them why. Patients that I have found that are the most successful in responding to the treatments are the ones who are questioning the treatment, asking what they're doing, what else they can do, and are really involved in their treatment plan, as opposed to the ones who are asking for a medication and hoping that that will fix it. So many integrative therapies exist for reflux and should be explored as part of the treatment regimen. They have superior outcomes depending on the patient's own desire to comply with the lifestyle program and patients for a trial and error approach. And PPI should be withdrawn when possible to avert long-term complications, which I have already mentioned. As we know, there are many long-term complications. So with this, what kind of advice can I give you as a physician for the future? As I was talking to web shadowers earlier, there are much more opportunities now to explore all the different types of specialties that are available for you. This is a great opportunity. You're getting to see a lot of different doctors and what they do in their day-to-day. But I would really highly recommend really explore the different specialties. Show up, be present, listen, observe, receive. Even if you think you're going to go into training to be a pediatrician, maybe you'll end up coming out and you'll be an OBGYN. I mean, I know I personally have had a very long, windy road. I went in thinking, internal medicine is the way to go. And I wish I knew about integrative medicine back then. It was not as common when I trained about 20 years ago. And there weren't as many programs available. So now definitely the programs are available. So I definitely highly recommend you connect with whatever doctors are available and see what they're really doing to see if that's the right choice for you. As always, having a good mentor in the space and developing good lifestyle habits yourself. That is, the career in medicine is long, and part of learning how to prevent burnout, which we are definitely seeing in our physician community, is having good lifestyle habits of yourself. Those good lifestyle habits, patients are now really becoming aware of. They respond better to doctors that they see actually live those lifestyles, as opposed to doctors who are just preaching, doing this and that, and then, you know, they're not doing it themselves. So really, you want to be your own, you're essentially your own example of what your patient can become. So advice to our future physicians: remember your why. There will be many challenging days and nights on this journey, but if you can remember why you wanted to become a doctor, who you want to help, it will be a worthwhile journey, even if it's long, and it is fundamental for your own happiness and success. So what is well-being? Well-being is, you know, it's essentially a non-negotiable for you to be happy and successful. So you need to figure out ways to do that. So with that being said, I do have a book out, which I mentioned in my last Web Shadowers talk. This book is now available on Amazon. You can also get it at beyondthepearls.net, where you can also find other educational resources for being a doctor, and you can also get it at Elsevier. I hope you enjoyed this talk. I'm gonna look over and see some of your questions, but if you wanna reach out to me, you can contact me at my website, drbhanote.com. I'm very easy to find on Instagram at Dr. Bhanote, Dr. Bhanote on Facebook, and at LinkedIn. I know a number of you have been contacting me since the last session, so definitely keep reaching out, asking your questions, and I'll try and help you in any way possible. So let me head over and see what the questions are. Wow, there's a lot of questions. So let me see. Are you able to spend so much time with the patient because you have a private practice, or do integrative medicine doctors usually spend 60 minutes or more with each patient? So yes, spending time with a patient is definitely a challenge of our healthcare system, because you know, essentially doctors are paid based on their RVU when they work for a hospital or they work for a private practice group. So you're paid on the number of patients you're bringing in and out. So if you're seeing, you know, 5 patients a day versus 30, that could make a difference in that type of setting. Unfortunately, that's because that's the way our healthcare system has evolved over time. And I can't say that it's evolved in a way where we're actually helping patients and truly helping them heal and resolve some of their symptoms and health issues. I personally see patients for 60 to 90 minutes, and I do that in my private practice, and I do not bill insurance. So what that means is I do not take insurance from patients. Patients are basically, it's a cash pay service. So they get to spend time with me, learning how to do this stuff, learning how to heal based on what their needs are. This is not available for every patient. I know one of my patients that I have right now did get a integrative consult at one of the top hospital care systems in our country. Actually, I won't name it, but they did. And they told me that their visit lasted 15 minutes as an integrative visit, and they did not go over 1/10 of what I did in their 1-hour appointment with me. So there are many models to how you can approach it. I know this is definitely a challenge for my colleagues who are working in the VA system and in underserved populations, because they really want to bring that type of care. So one way is to really break it down into smaller amounts, where maybe you're addressing nutrition in one visit, sleep in another visit, and kind of exercise at another visit and maybe breaking down those categories. So I'm getting another question here. How would surgeons do an integrative medicine and change their course of advice, treatment? Well, like I said, essentially anybody who has completed a residency in any practice can do integrative medicine fellowship. There were a number of surgeons that were, and even, so I said OBGYN surgeons, regular surgeons, even radiologists who were in my program, who then went back to do integrative medicine fellowship. Now, with that fellowship, they have started adding some of those techniques, and they've seen healing in their patients and how their patients respond to the surgery. So it's not a matter of abandoning one field over the other. It's truly a matter of applying an integrative or a whole body approach where we're not just looking at the disease as a silo, and we're actually looking at the patient and all the different things we can do for the patient. So let me go back up to some other questions. Let's see. Okay, yes, I'm able to. What are the aspects of your specialty that are most rewarding and most challenging? So I will tell you the most rewarding thing is that the patients that I'm seeing, you know, they're definitely not easy patients. They have complex issues. In fact, some patients have been dumped by their physicians previously, where they've gone to a number of physicians, and because they ask too many questions or they want to know if they can do this or that, they've been dumped by them. And they actually have a very jaded opinion of what a doctor is. And at the end of the day, any doctor, you know, I would hope is there to really help and heal the patient. So one of the most rewarding things is, you know, I had a patient come to me and say, you know, Dr. Bhanote, in just 2 weeks of changing the things that I have done in my lifetime, I am able to sleep better. I am eating better. I just have more energy. And that to me is so rewarding, because that is somebody who has been suffering for 10 to 15 years. And for me to see that in just 2 weeks and see that tremendous change, that is very rewarding. A challenging thing in the field is, definitely having both patients and also explaining the patients to the patient, because with integrative medicine, there's no quick fix. So at least personally for me, if you're coming to me as a patient, I am not going to start you on a medication right away. We are going to work on an integrative plan, and an integrative plan generally takes longer in the body to heal. So it takes a number of years for your disease to develop. So it's amazing to me that people think that they can come into an appointment and think that with one appointment that all of a sudden their disease is going to disappear. And I know that there's people who have tried medications, and even then, after time, those medications stop working. So that is definitely one of the challenging things, is having patients realize that, you know, it's going to take some work on their part, and but now they have a real partner in their healing process, and we're here to help. So let's see. Are there any books, textbooks, articles you recommend to learn more about integrative medicine? Yes, actually, I will pull this up. All right, so this is basically, it's Expert Consult. It is the, you know, textbook of integrative medicine. There is one for each of the specialties. This is David Raquel. This is the one you need to understand for your boards. It is broken down into all the different things I've talked about. And what's great is it's also broken down into different diseases. So you open it up, you can look at integrative approaches that are evidence-based for chronic sinusitis, for uterine fibroids, for, let's see, integrative approaches to breast cancer, which is one thing that I deal with a lot with my patients, osteoarthritis. And this breaks it down into what is the evidence and what is not the evidence. So that would be a book I would recommend. It's just like any of the other textbooks we use. They're very heavy and full of information. As always, you can reach out to me and you can follow along. I also have a free newsletter available at my website where I commonly provide information on integrative approaches for different things that's sent out twice a month. So you can head over there and sign up for that. Let's see. Let me do one last question. I want to make sure I get your questions answered. Let's see. How do you keep up to date with the latest research and best practices? Moreover, how do you decide if something that you want to implement into your practice or not? So definitely keeping up to date. Part of that is being part of, the integrative medicine organization where I trained at. We have practitioners from all over the world that we communicate with to see how, if we have a question about a patient and if anybody's dealt with that kind of situation. We also have specific working groups. I'm part of a integrative oncology working group where we discuss different cancer patients and their treatment. So we are keeping up to date on the evidence base, and it's great because some of our practitioners who are in academia are also working on the research side of it. So they're contributing to the number of studies that hopefully we can get more of them out there. So okay, I'll do one more. I am planning is a long process, but how long is it typically? Months, years, or does it really depend? So I am planning depends first on if we're dealing with one entity disease, one symptom, or if we're dealing with a host of them, what the level of the disease is, how chronic it has been. Everything is best when it's prevented. So I always say to my patients, come to me before the disease develops, but if the disease has developed, then we'll figure it out. It's a lifestyle anywhere from, I see patients anywhere from 6 to 8 months. They show dramatic improvement in the first month, but this, it just depends. And then it's just like anything else. I see them for 1 or 2 visits every year to follow up, especially if there's life changes going on, if they're, aging, or if we're dealing with new health issues, hopefully we're preventing them. So, and that would be it. So thank you, web shadowers. I actually have some patients to go see. So I enjoyed being with you again. Hopefully I can be back with you again in the spring and tell you a little bit more and show you some more case studies with this. And then until then, reach out to me on social media. I look forward to chatting with you all.
Thank you so much, Dr. Bhanote. This was a wonderful presentation. We all learned so much. It was so informative. For all our viewers, the Google form for attendance has been posted in the YouTube chat box. We will actually no longer be posting it in our Instagram bio, just to make sure that everyone filling it out is actually on the YouTube watching. Additionally, please make sure you only fill out the Google form once. If you fill out multiple times, we will only track the first time you fill it out. And thank you all so much for joining, and thank you